Okay, this is finishing up the lecture over depression. We're starting with the first nursing diagnosis, which is risk for suicide, self-directed violence. And that can be related to many of the risk factors that we've already gone over in class. If you remember, what are some of those risk factors? Any of the demographics that were in the chapter, any type of losses that a person might experience would be a risk factor. So that's what we're, any other type of precipitating factors. The fact that they have, the suicidal plan would also be a risk factor. Okay. Outcome. Well, let me just step back and say that risk for suicide, because it is a safety issue, because it is a life or death issue, if you will, is always going to be our top priority because it falls under safety, so it's always our top priority. Our outcomes, we do want the patient to experience no physical harm if they're in the hospital while hospitalized. The patient will develop a safety plan to use, say, in the hospital or to use as an outpatient, and the patient will express optimism and hope. So those are the outcomes that we want for our clients. Interventions. In Chapter 17, there is a care plan on Table 17-3, and that care plan with all those interventions, I want you to know those. Okay? So make sure that you read through that, understand it, but also can tell me what are the nursing interventions for the client will not harm themselves. Okay? What does the nurse need to do? And then also note the rationales. General guidelines, I'm going to go over some of those general guidelines. Okay, we are always going to be assessing our client to see, again, seeing where they are at with their thoughts of wanting to harm themselves. So we're going to ask those assessment questions that we talked about last class. It may be every shift, but if your patient is actively suicidal, it might be every 4 hours, it might be every 2 hours. We want to make sure that we're creating a safe environment so that all, things that a person may harm themselves with are removed from the environment. We want to keep a close observation on them, and close observations is going to depend on what type of precautions that the patient might be on and the specific unit they are on. Some units will have an actual policy that says suicide precautions, and if a person is on suicide precautions, they may need to be in a certain type of hospital gown or a certain type of scrubs. If they are on suicidal precautions, removing their shoes, belts, a variety of things on that nature. It may be that the suicide precautions also dictates how often checks will be. It might be constant supervision, like on a 1-to-1, or it might be every 5 minutes, it might be every 10 minutes, every 15 minutes. So again, it's going to, that close observation, suicide precautions is going to depend on where you're working on that specific unit. But to know that the client needs to have close observation. We need to give special care and medication administration. And again, why do we need to do that? There are those clients who will have a plan of overdosing on pills and may cheat their medications and hide them until they get enough meds where they can actually overdose. I already talked about making rounds frequently and at infrequent intervals. So if the patient can count on you wanting making a check on him every 15 minutes, he may plan to do something like hang himself or another, usually it's hanging with that's in the hospital, or cutting himself in that 15-minute interval. So it's important that we do that irregularly. So instead of, as you're making rounds, you might double back and you might check on that person at 12 minutes or at 10 minutes, but that you're doing them frequently. We also want to encourage the patient to express their honest feelings, and in order to do that, we have to have a therapeutic relationship, and we have to have trust developed. So all the things that are involved in that, but really to be sitting down with them, talking about feelings, talking about what's going on. Suicide precautions. Oh, I need to be on the next. Suicide precautions. I already talked a lot about that. It varies depending on the unit. Some hospitals will have, like I said, a 1-to-1. Some will say they have to be in the day room, where they can be observed constantly. Some people will say no private room, that they have to be in a room with a roommate. Many times, if the patient has to go off unit, that they have to be accompanied to any off unit activities. On page 513, I want you to look at the orange bullet points that talk about interventions for risk for suicide. I already mentioned a lot of those, but let's see if there's anything else. Helping the patient to identify community resources for support, making sure that they're oriented to reality, spend time with the client. That's going to ensure safety, but it also will ensure security for them. Unconditional acceptance, frequent assessments. I'm kind of repeating myself. Creating a safe environment. Those are all important that fall under that page 513 bullet points. We're also going to be looking at if the patient is improving. We want to encourage them to start looking at positive coping mechanisms and teaching them positive coping mechanisms, helping them to recognize when to use those positive coping mechanisms. That might be talking, it might be relaxation, it might be yoga, it might be any types of coping mechanisms. Okay, discharge planning here. A client who is suicidal and following discharge. Okay, so if you have a patient who is already discharged, they're on outpatient, what if they're suicidal? Well, we want to, if we're talking, say, on the phone to them or even before they're discharged, we want to put into place a safety plan. And box 17.2 talks about essential components for a safety plan, and I want you to know those as well. And I'm not going to read through all of those. But I'll mention a few of those. We want to make sure that before they're discharged, they do have immediate access to a support system, whether that be family or a halfway house or some type of support system. We want to help them recognize what are warning signs that precede a suicide crisis. So if they start having negative thoughts, if they start feeling like they don't want to be around anybody, if they start thinking about wanting to die, those might be some early symptoms, or they're not sleeping well, early symptoms, and to let somebody know about that. They should identify what their personal coping mechanisms are and then work on those. And if they start to have those signs and symptoms, then just start to work on those coping mechanisms. Know a supportive family member or friends that they can call to help. Identify people who are in their social settings that might be able to help. Maybe they don't have friends or family around, but maybe there is a counselor they can call. Maybe there's a halfway house individual that they can call. Identify resources and mental health professionals that they can contact. Again, kind of along those same lines, but a counselor, crisis line, emergency room. So to make sure that this whole safety plan is, it may be written out, and that's always a good thing, so that they have that, but it might be things that it may not be written out, but that you just talk about those things and make sure that the patient understands those. Okay, and then I also want you to look at page 308 when it talks about educating the family. That starts on page 308 and goes into 309, so to look at that as well. And that's all that I have for this PowerPoint, and the next PowerPoint is going to finish up these nursing diagnoses and then also go into medication.